This short video will give a broad overview of uveal melanoma, a cancer of the eye. We begin by analyzing the demographics and statistics of uveal melanoma. We then move to its specific causes and how it spreads before arriving at current treatments, and finally, treatments that are being developed. So, what is uveal melanoma? At the most general level, uveal melanoma is a cancer of the eye. It arises from melanocytes present in the iris, ciliary body, and choroid layer of the eye. Seen here are some examples of uveal melanoma tumors. The major common factor among uveal melanoma cases is ethnicity. In fact, 98% of patients are Caucasian, suggesting that uveal melanoma is due to genetic predisposition and is not environmentally linked disease. When the age of onset is tracked, it is clear that uveal melanoma, like most cancers, is a disease of aging. Uveal melanoma is a rare disease, with just 5.1 cases per million people per year. The 5-year survival rate is around 80%. However, the 10-year prognosis is poor, with 50% of people experiencing metastasis regardless of treatment type. This establishes the need for further research into treatment of this disease. However, before we can treat the disease, we must examine its roots. Here, we seek to understand how uveal melanoma occurs. Uveal melanoma is the most common intraocular cancer of the eye. There are two prognoses: anterior or posterior uveal tract cancer. ET3 and HGF signaling control are very important pathways within the uveal tract melanocytes and are likely involved in the development of uveal melanoma tumors. On a cytogenic level, these mutations take place on chromosome 1, 3, 6, and 8, but most commonly on chromosome 3, a common factor in metastatic cancers. There are several driver genes associated with uveal melanoma, but the 5 most common ones are GNAQ, GNA11, BAP1, EIF1AX, and SF3B1. GNAQ and GNA11 are two oncogenes responsible for producing the alpha subunit of the G protein that mediates signaling between the G protein coupled receptors and downstream effectors of the MAPK pathway. The constitutive activation that results from mutations in these genes is due to a loss of GTPase activity. This constant signaling by the G protein upregulates the MAPK pathway and can lead to uncontrolled cell growth and proliferation, effectively causing cancer. BAP1 is a tumor suppressor gene located on the short arm of chromosome 3 and encodes a protein called ubiquitin carboxyl hydrolase BAP1. The function of this enzyme helps to regulate several cellular processes, including cell growth, cell division, cell death, and DNA damage repair. Uveal melanomas at a high risk of metastasizing usually lack a chromosome 3 homolog associated with loss of function mutations in the BAP1 gene. IF1AX is an X-linked translation initiation factor that encodes a protein that interacts with mRNA to induce translation. Therefore, mutant version of this gene will cause abnormal translation of mRNA. SF3B1 is a gene that produces a spliceosome subunit. When mutated through a hotspot mutation at arginine 625, it can cause errors in mature mRNA transcripts, but further issues may arise because of the role it plays in DNA repair. With 10 to 24% frequency in uveal melanoma cases, it is often found to be a mutated gene when the patient is much younger. Mutations in this gene are associated with having later metastasis of the cancer, often 5 years after the uveal melanoma diagnosis. Now we look at current treatment options for uveal melanoma patients. There are a variety of options, but the most effective treatment varies from patient to patient. Historically, patients were treated using enucleation, or the removal of the entire eye. However, this treatment option has the obvious downside of partial or complete blindness. A more precise treatment is brachytherapy. Brachytherapy is a radiation therapy technique in which a radioactive plaque is sutured into the sclera, which shrinks the tumor. Brachytherapy has the advantage of administering targeted high doses of radiation, although, as with any radiation treatment, it is toxic to neighboring tissues. Laser therapy, or the use of focused thermal energy, is another treatment option. This treatment is known as photocoagulation or transpupillary thermotherapy. It is most effective in treating small lesions by destroying cancerous cells before they have spread. Finally, surgical resection targets and surgically removes malignant melanomas from the eye. A transscleral resection removes the melanoma of the ciliary body, while a transretinal endoresection targets posteriorly located tumors that do not involve the ciliary body. Studies have shown that surgical resection leads to more retention of visual activity when compared to brachytherapy due to minimal damage to surrounding tissues. However, surgical resection is a complicated operation, and any imperfection in the surgical removal can lead to tumor recurrence, retinal detachment, or submacular hemorrhages. We now look to future treatments for uveal melanoma. There are 3 main categories of drugs currently under development to treat uveal melanoma. The first category is immune checkpoint inhibitors. These are monoclonal antibodies that inhibit interactions between immune checkpoint proteins, enabling T cells to recognize and attack cancer cells. Metastatic uveal melanoma responses to ICI monotherapy are around just 0 to 7%. However, an ongoing phase 2 trial studying novel immune inhibitors reported a 12% response in 50 previously untreated patients with metastatic uveal melanoma. Evidently, combined ICI therapy shows promise. Also currently being researched are cancer vaccines. These are designed to train the immune system to better recognize tumor-associated antigens on cancer cells and destroy them. There's a new phase 1 trial which will evaluate the efficacy of an mRNA cancer vaccine. IKKB, a kinase, phosphorylates inhibitors of the NF-kappa B signaling pathway, and in turn, free NF-kappa B is translocated into the nucleus where it activates the transcription of hundreds of genes involved in the immune response, growth control, or protection against apoptosis. These IKKB matured dendritic cells located with RNA coding for tumor mRNA with defined tumor-associated antigens and driver mutations show very strong potential as treatment for cancers like uveal melanoma. Finally, adoptive T-cell therapies remove T cells from a cancer patient, isolate and expand them ex vivo, and then reinfuse them into the patient. This attempts to enhance the immune system to more efficiently attack cancer cells by creating super T cells. Unfortunately, a trial in this field was terminated in 2018. However, a larger scale phase 2 trial is currently recruiting to evaluate a lymphodepleting preparative regimen consisting of several novel drugs followed by an infusion of autologous T cells and high-dose IL-2 in 59 patients with a specific type of uveal melanoma. This treatment shows more promise in the treatment of uveal melanoma. Thank you so much for listening to this presentation, and sorry for all the jumbo words, but I hope that this was educational and has enlightened you to the current state of uveal melanoma and where the field is heading. This presentation would not have been possible without all of the fantastic papers and sources that we used, and here they are. Again, thank you so much.